This is my presentation on hyperbaric oxygen therapy. Hyperbaric oxygen therapy is a therapy used for gas embolism, carbon monoxide poisoning, severe anemia, traumatic ischemia, and also to enhance healing of problematic wounds, including diabetic wounds. Radiation necrosis of soft tissue and bone, or refractory osteomyelitis, is also part of indications. In hyperbaric oxygen therapy, a patient's entire body is placed into a pressure vessel, and the ambient pressure is increased within the vessel, usually to 1.5 to 3.0 atmospheric pressure, using 100% oxygen. This allows delivery of high amount of oxygen to the tissues, not because of 100% oxygen, but from the increased atmospheric pressure. For example, at 3.0 atm, under 100% oxygen, your entire body holds enough oxygen to sustain basal metabolic requirements without any oxygen transportation by hemoglobin. Now, topical oxygen therapy is a very different treatment. For topical oxygen therapy, an airtight chamber or polyethylene bag is sealed around the limb or the trunk by either a constriction device or by a tape, and high flow oxygen, usually 10 liters per minute, is introduced in the bag and over the wound. Pressures just over 1.0 atm, typically 1.004 to 1.013 atm, are recommended because higher pressure could decrease arterial or capillary flow. This therapy still greatly lacks in scientific evidence. In an experimental base, there was an increased healing time for experimental wound on a pig, which was applied 100% oxygen topically in a similar manner. However, the specific mechanism behind this is still under investigation. Now, by explaining individual treatments, I wanted to make sure everyone understands the difference between this and this. And of course, certainly not this. So, what is the evidence behind hyperbaric oxygen therapy for prevention of osteoradionecrosis? The only randomized controlled trial done was way back in 1985, which compared prophylactic hyperbaric oxygen therapy group and the group treated with amoxicillin. Only 5.4% of hyperbaric oxygen therapy group developed osteoradionecrosis, compared to 29.9% in amoxicillin group. Well, this is the article I talked about, the experimental model of topical oxygen application. Now here's a Cochrane review published in 2008, which concluded that there are no statistical difference for implant failures for irradiated jaw with or without hyperbaric oxygen therapy. In 2010, Fritz G.W. et al. Concluded there are insufficient information to show that hyperbaric oxygen therapy reduces the incidence of osteoradionecrosis in irradiated patients requiring extraction. Most recently, in 2012, however, Cochrane review concluded that there is significantly improved probability of healing irradiated tooth sockets following dental extraction. However, the risk ratio was only 1.4 and number needed to treat was 4, which is not very great for such expensive and time-consuming procedure. There is a randomized controlled trial of hyperbaric oxygen therapy for treatment of bisphosphonate-related osteonecrosis of jaw, which included 46 patients. And in this study, they failed to show significant benefit over normal treatment group. So to conclude, hyperbaric oxygen therapy is still in debate whether it is worthwhile for prevention of osteoid radionecrosis or even treatment of bisphosphonate-related osteonecrosis of bronch. Now, topical oxygen therapy is not as same as hyperbaric oxygen therapy, and at this point, there seems to be no good scientific evidence for application of topical oxygen therapy in orofacial region. Thank you very much for your attention.